All righty, guys. Good afternoon, everyone. Thanks for tuning in to our biannual resident Clinicopathologic conference over here at Emory. I hope we have an interesting case for you all that will come with tons of learning. So what I'm going to do is I'm going to begin by introducing our speakers for today, starting with the star of the show, our case presenter, and the one who will be leading the majority of the presentation, Shree Patel. So Shree is a first-year internal medicine resident here at Emory, previously attended the Southern Illinois University School of Medicine. His clinical interests include research on the gut-brain axis and preventative medicine. Outside the hospital, you can likely find him on the tennis courts or going on long walks around Piedmont Park and Atlanta. And next up, we have our specialty discussants. And I will start with Dr. Spencer Hutto. Dr. Hutto is an assistant professor of neurology at Emory University, the associate program director for the adult neurology residency, the director of the Emory Neurosarcoidosis Clinic, and a member of the Neurohospitalist Division stationed at Emory University Hospital. Thanks for joining us, Dr. Hutto. And last but certainly not least, we have Dr. Lucy Witt. Dr. Witt is an assistant professor of medicine in the Division of Infectious Diseases at Emory University and is the hospital epidemiologist for Emory Johns Creek Hospital, as well as the medical director of their antimicrobial stewardship program. Dr. Witt is a co-principal investigator for the Georgia Emerging Infectious Program, otherwise known as Georgia EIP. Her research interests include hospital onset infections, multi-drug resistant gram-negative bacteria and yeast, as well as antimicrobial and diagnostic stewardship. Clinically, Dr. Witt has a special interest in immunocompromised patients and sees patients on the general and transplant infectious disease consult teams at Emory University Hospital. We're real excited to have our discussants share their expertise in this case. Now, without further ado, I'm going to pass the mic over to our case presenter, Shree Patel. Shree, whenever you're ready, man, please feel free to take it away.
Okay, so for our case today, we're presenting a case of a 59-year-old male with no recorded past medical history. And so this patient initially presented with 6 to 8 weeks of intermittent headache associated with some other transient neurological symptoms. And so this headache was described as constant, lasting 2 to 3 days at a time, located in the frontal and posterior regions, sometimes solely left-sided. And he described the pain as a throbbing sensation with some associated tingling and numbness in those regions of the head. He described some transient improvement with over-the-counter ibuprofen. So now these headaches were also associated with some other transient neurological symptoms. So some of those that were recorded include blurry vision, loss of balance, dysarthria, left-sided weakness, and this has been going on for a couple months. And these symptoms would occur during the same time as the headache, but it was recorded that they would resolve before the headache resolved. And we do not know how long these symptoms would last. It was also reported that this entire symptomatology worsened when the patient was standing rather than laying down. So, because of all these symptoms, this patient eventually ended up visiting the ED multiple times, up to 3 different times. And during those visits, a preliminary stroke workup was performed. And so he had gone on multiple CT non-cons as well as CT angiographies. All of those were unrevealing. During those visits, nerve exams were unremarkable, and then no further imaging was done. He was ultimately referred to his PCP and neurologist outpatient for further workup. And so just some other information about this patient include, again, no recorded past medical or surgical history. He takes no medications. He reports no allergies. Now, his social history is relevant for the fact that he recently emigrated from Kyrgyzstan 7 years prior, and he's primarily Russian speaking. So after he immigrated, he now stays in Georgia with his wife. Social history also relevant for tobacco use, 30-pack-year smoking history. He quit 2 months ago. Alcohol use was not recorded, so unknown quantity and duration. No sick contacts. He's been monogamous with his wife of 25 years. No known animal contacts. For work, he actually works as a long-distance truck driver, and he had roots throughout the entire United States. He previously worked as a caregiver for elderly patients. And just a hobby that was seen was that he used to be a beekeeper in the past. And so that kind of rounds out our first aliquot for this patient. Oh, family history again. He denies any history of malignancy or autoimmune disease.
Great. So now we can let Dr. Hutto take over. Dr. Hutto, we'd love to hear how you would approach a patient presenting with this constellation of symptoms.
Sure. Well, thank you all for having me. I really appreciate the opportunity to be here today and present the neurological perspective on this case, which is an extremely interesting one. So, I was asked to discuss, the initial approach to headache. And so, when I see patients in the hospital, I try to think through a little bit of, do I think this is a primary headache disorder or do I think it's secondary to something? And when I see those patients, I kind of go through a few things to make that determination. And so, the first is a nuanced history that we're going to talk about in some detail in just a moment. Performing a careful examination, so that includes the routine screening neurological examination, but portions of the exam particularly pertinent to headache, like the cranial nerves, for instance. A sort of a mental checklist of what are some of the red flags that might force us to think about secondary etiologies, and then whether or not I think the patient needs some sort of imaging up front. And so, in discussing the approach to headache, I know many of you will be familiar with just the general history taking. I think there are a few nuances to the history of headache, and the first one is the manner of onset. So we want to know, is this a headache that happened in a thunderclap fashion, sort of all of a sudden? Did it take some time to build up? Because that can suggest more worrisome etiologies like subarachnoid hemorrhage and reversible cerebral vasoconstriction syndrome. I want to know where it's located. If it is a headache that is side locked every single time, then that suggests that there is some underlying pathology likely. Migraines are oftentimes unilateral, but they'll oftentimes switch sides. We want to know, is it something that's lasting for seconds, hours, days? Has it been constant since onset? What is the general quality? Patients with migraines will describe a throbbing sensation. Patients with tension type headaches will talk about how it's a squeezing vice-like sensation of their temporal regions, and patients with subarachnoid hemorrhage will describe it as the worst headache of life. We do want to know what makes it better and what makes it worse and what symptoms are associated with that. And so we've heard a bit about that, so far in the case, worsened withstanding, and also some associated neurologic symptoms. And then finally, it's important to know what the patient's been using to help alleviate the headache. Sometimes taking too many over-the-counter analgesics can actually paradoxically make the headache worse. And this is common in patients coming to the hospital for headache. And then specifically, we want to know, do they have any phobias? So are they sensitive to light or sound? Do they have nausea or vomiting? Those things are common with migraines, but they can also be seen with meningitis and sometimes with raised ICP. We want to know what they do when they have their headaches. So are they the person who lies down in a cold, dark room? Or are they extremely agitated by the pain where they're up pacing around that might occur with a trigeminal autonomic cephalgia? And then, does it get better or worse with standing or lying down? Patients with low ICP will describe headaches that worsen being up on their feet. That essentially goes away lying flat. Almost all patients will say, though, being up on their feet makes their headache worse because they're being active, and activity generally makes headaches worse. And then in the review of systems neurologically, we focused on, is there focality? Do they have, symptoms that raise the concern for raised or lowered ICP, like we've talked about? Do they have visual disturbances? If they're over 50, we routinely ask, do they have fevers, chills, weight changes, jaw claudication, head or shoulder, achiness that might suggest GCA? And then we want to know, are there systemic or constitutional symptoms associated with it? And then finally, I just ask patients to tell me if there's anything unusual in the last few weeks. And a lot of times that's very revealing of what may have precipitated the headache. And so that's my sort of open-ended final pass at anything that could explain the headache. And then you want to know, do they have a history of headaches? Sometimes patients will forget that they had migraines in their teenage years to suggest that it still could be a primary headache. Have they had any neurosurgeries? Are they febrile? Is their blood pressure 250? Might, lead to headache. And then the standard neurological examination we do, but we also want to pay particular attention to cranial nerves that traverse the meninges that can give rise to headache if it's inflamed. We want to know, are the optic disc edematous that suggests raised pressure? We also palpate the sinuses, look at the orbits, because if somebody has orbital cellulitis and it's obvious externally, that can lead to headache. We again examine the temporal arteries for signs of GCA, and then look for meningeal signs on exam. And then when we think about things that raise the alarm, these are some of the things that I try to process mentally as a checklist in my mind. And I would say in this case, so far, we've heard several things that should raise our concern. So the first is that this is a patient in his 50s, 59, with new onset headaches with really no other past medical history. So there's something unusual about that. Most primary headaches occur younger in life. There is a history of smoking a lot for 30 years, it sounds like, and lung cancer in particularly is frequently metastatic to the brain, or that's one of the most common primary malignancies that metastasize to the brain. There's some worsening with standing. Again, that could just be an activity phenomenon, but it got worse with standing. So, think about low ICP in that situation. There's very clearly focal neurologic symptoms associated with the headache, and that's sort of a strict red flag in my mind that a patient needs additional workup. And then I would just say it doesn't necessarily get me excited that a patient's coming to the ER multiple times with headaches, but for someone who really doesn't have headaches and doesn't have a medical history, coming to the hospital multiple times unexpectedly is a concern. And so I would conceptualize this as a new headache with vocality associated, and I think we can divide our differential a little bit based on if the focal symptoms are constantly present versus transient. If it's constant, it suggests that there's actually an underlying insult to the brain. So maybe there's a mass present, there's a ischemia, the patient's had a hemorrhage, maybe they've got encephalitis. If it's transient, that could be because of intermittent impaired blood flow to a certain portion of the brain. So you can see that with vasculitis and with vasculopathies. You can also see that as a manifestation of seizures. People can have postictal phenomenon and deficits. If they have a parenchymal focus that is somewhat on the smaller side, that could give rise to seizures that maybe a CT would miss. And finally, sort of a diagnosis of exclusion, especially in a guy who's 59, but sometimes complicated migraines can be associated with deficits. In our guy's case, I guess I'm leaning a little bit more to, vasculopathy, vasculitis. Is this something that is, a primary neurologic autoimmune disorder? Is it infectious? Could it be reversible cerebral vasoconstriction syndrome, given its association with intermittent deficits? And then we have to still consider the possibility of intermittent seizures, even though that's not really reported in the history. We just kind of keep it in mind. But I was asked, what would I do next? I'm a neurologist, so I'm definitely going to say an MRI of the brain with and without contrast. I also think vessel wall imaging is important because sometimes it can identify inflammation of vessels that would suggest vasculitis, and then a SED rate and a CRP to screen for GCA. And then probably we're going down this path, I'm guessing, CSF analysis, body imaging, vasculitis labs, and maybe consideration for an angiogram and EEG. And that is all I have here.
Awesome. Thanks, Dr. That was amazing. It was great to hear that from the neurological side of things. Now, Shree, I'd love to hear more about how this patient did with his follow-up after all these ED visits.
Yeah, so exactly. So, after all these ED visits, he was eventually able to establish care with the PCP. We didn't have the records available for those visits, but his PCP did end up getting a cardiac CT scan, which had an incidental finding of a 3 centimeter lower lobe cavitary mass with surrounding nodular infiltrate. And so this really shifted the differential here. And the patient was actually subsequently referred to outpatient pulmonology. And I have some representative imaging here of this cavitary mass that you can see. And so patients then went and saw a pulmonologist. And actually during that visit with pulmonology, they were able to reveal some additional information. And so the pulmonologist was able to find out that at the onset of headaches, the patient actually had one episode of right-sided pleuritic chest pain and cough while he was working as a truck driver. He went and saw healthcare. There was a presumptive diagnosis of bronchitis, was given antibiotics of unknown what the antibiotics were or the duration of the antibiotics, and then his chest pain subsequently resolved. He also found out that this patient was having drenching night sweats, fatigue, and a 6 kilogram weight loss. This eventually led to the patient to stop working, and it's actually what prompted him to stop smoking as well. Okay, so now that all this new information came out with this cavitary lesion and weight loss, and as well as night sweats, there was a concern for malignancy. And so the pulmonologist actually ordered a PET CT scan to kind of evaluate for a potential malignant process. And the results from that scan showed a hypermetabolic 3.3 centimeter posterior medial right lower lobe pulmonary mass that the official impression read as most concerning for primary lung malignancy. Also showed multiple hypermetabolic lymph nodes consistent with a metastatic disease, and then as well as some osseous metastatic lesions. Okay, and so after that, because of these findings, the patient underwent an outpatient bronchoscopy and endobronchial ultrasound. And so that revealed no endobronchial lesions and or any mention of abnormal secretions during that bronchoscopy. And during that procedure, the following specimens were collected and sent to the lab. So they went ahead and got cultures, AFB, fungal, bacterial, and tissue, as well as a gram stain from the right lower lobe, cavitary mass. They got transbronchial biopsies, as well as cytology from this right lower lobe. And they also got a transbronchial needle aspirations from some of the affected lymph nodes. And so then after this procedure, the patient went home. And the very next day, this patient represented to the ED, this time with acute onset left-sided headache, facial droop, left upper extremity, and left lower extremity weakness and numbness. This lasted for a total of 10 minutes, and actually the symptoms completely self-resolved before he was evaluated in the ED. And so just some review of systems from that ED visit. Again, positive for a lot of the information we presented prior, the night sweats, the fatigue, the weight loss, this blurry vision, as well as a single episode of pleuritic chest pain, and then the headache and dizziness, dysarthria, blurry vision, weakness and numbness. Physical exam at that time was actually unrevealing. So again, his symptoms resolved by the time he was evaluated. So this was the documented physical exam, which again was all within normal range. The neuro exam was also unrevealing. So mental status, awake, alert, oriented times 4, speech, clear and fluent, cranial nerves intact, motor was 5 out of 5, sensory, coordination, reflexes, and gait, all within normal limits during that evaluation. Okay. So vitals during this admission. So vitals, again, pretty benign. Temperature of 98.1, blood pressure 140/81, heart rate 53. I'm not going to go through all the CMP and CBC, but also fairly benign. No real abnormalities that stuck out to the clinical team at that time. So again, this patient came in with a new transient neurological deficit, right? Left-sided weakness. So the team went ahead and pursued further imaging. And so our CT non-con at that time, again, showed no acute intracranial process. However, the CT angiography that was also done during this visit showed these bilateral pulmonary lesions, which we had already seen prior. And the read actually said possible acute infectious etiology of these right-sided lesions. And so this time around for our patient, he was actually admitted to the hospital and was able to get some further workup, including an MRI. And so our MRI for this patient showed nodular leptomeningeal thickening and enhancement with diffuse involvement centered around the basilar cisterns, circle of Willis, sylvian fissure, and cerebellar folds. Enhancement is also seen about the bilateral insular cortices. And you can see here on this imaging, we have some arrows kind of pointing out where the leptomeningeal enhancement was seen. It was fairly diffuse. And then this next slide's kind of a timeline of everything that happened bringing this patient into his current presentation. So again, 2 months prior, he had this one-time episode of pleuritic chest pain, an ED visit that was normal for the CT scans during that time, didn't show anything. He started having these night sweats, fatigue, weight loss, another ED visit 1 month prior, also no acute findings, referred to PCP. 2 weeks prior, PCP did this chest imaging, which then found the cavitary infiltrate, PET scan performed, bronchoscopy done, results pending. And then this time he presented to the ED with this left upper extremity weakness and the MRI showing the leptomeningeal enhancement.
Thanks for that info, Shree. And this is a great opportunity for Dr. Witt to step in. Dr. Witt, with the data that we have now gathered, how do you use it to generate a differential? And what are further diagnostics you would pursue to assist in narrowing this differential?
Sorry, oh, you guys are seeing the right thing now?
Yeah.
Great. So, hi, thanks for having me, Daniel. I'm an infectious disease physician assistant professor and going to go through my thoughts for further workup at this point with this interesting case. So first, I always love to make a case representation and summarizing what Shree's given us so far. This is a 59-year-old gentleman with no past medical history who has had 2 months of headaches, neurologic disturbances, weight loss, and night sweats. And these are severe enough to the point where he stopped working and quit smoking. And this patient has some unique risk factors. And, as an infectious disease doctor, I love talking to people about their exposure. So he's born and lived in Kyrgyzstan, which is an endemic area for tuberculosis. And he's a long-haul truck driver, although we don't know exactly where he's driven. Are we talking up and down the East Coast? Does he go to Arizona and Texas? Does he go to Minnesota? He also has an extensive tobacco exposure history, and appears to have, chronic alcohol use, although I'm not 100% sure what that means. Is that, 2 drinks a day for many years? Is that binge drinking to the point where he passes out and aspirates? But some sort of alcohol use. And other important findings thus far include that he has, a cavitary pulmonary lesion with PET avid lymph nodes outside of the chest wall, as well as diffuse osseous lesions. Interestingly, he has relatively normal labs, and by that, I was looking specifically at a normal white count with a normal differential and nothing, on flow that would suggest abnormal lymph cells floating around. He had normal hemoglobin and platelets. His kidney function appeared normal, and his liver function was not elevated. He also had a normal glucose level, which obviously doesn't rule in or rule out diabetes, but a normal glucose level walking into the emergency room makes me think he doesn't have DKA or kind of an undiagnosed diabetes that would be important to his workup. And of course, very interestingly, on the MRI, he has this what's described as nodular leptomeningeal enhancement. And when I approach a case, being a more junior faculty member, I always try to make sure I can explain all the things and that I haven't left anything off of my list. This, helps me create a differential, but also helps make sure that even if I don't have a single disease that explains all of the things, I've noted to be abnormal, I'm definitely considering it in my treatment. So I'm not, giving hepatotoxic agents to a patient with elevated liver enzymes, or giving, marrow suppressive agent to patients who have already have low blood counts. So for this patient, all the things that I want to explain are the leptomeningeal disease, the cavitary lung mass, and the bone lesions. And this is all in the context of the fact that he's a truck driver, a chronic smoker, and he was born and lived in Kyrgyzstan. And as I mentioned, I have no reason to believe this patient is immunocompromised. None of the data being given thus far suggests he is, and this is super important. I do transplant infectious disease part of the time, and patients who don't have a working immune system can have, a broader range of infections and can have infections present in an unusual way. So if it turns out he is immunocompromised, I'm really going to have to change the way I'm thinking about this this patient. What I want to do is create a Venn diagram, in my head about potential causes of these abnormal findings, and then find out what fits right there in that middle section. I'm going to start with the meningeal disease. And, being a part of our division in infectious diseases, of course, I love buckets, trained under Varun. Yep.
Are you trying to show slide? Because the slide is just stuck in discussion.
Oh, no.
No, Lucy, you're okay. You're on explain all the things for me. Carlos, I think you have to do the thing where you click on the top right.
Are we good?
Yeah, I got it. Thanks.
Okay, great. So the buckets that I like to do, and I'm sure are familiar to many on this call: malignancy, inflammatory, and infectious causes. And for malignancy, things that I think about that cause meningeal disease in terms of metastatic disease are breast, lung, and melanoma, but actually primary brain lesions can also cause meningeal disease. Inflammatory pathologies like sarcoidosis, vasculitis, and post-procedural you can get some inflammation of the meninges. Then, of course, infectious, West Nile virus can do this, Lyme disease, some typical bacteria. I'm thinking about things like Staph aureus Klebsiella, tuberculosis, and then the fungal infections like dimorphic fungi or mold. But this patient was specifically described as nodular leptomeningeal disease, and leptomeningeal disease specifically refers to the subarachnoid and pia tissue, which is protected by the blood-brain barrier and requires an actual injury for contrast to leak from the blood vessels into this tissue. And generally that's caused by things like bacterial viral infections. And my understanding is that those infections cause like a thin linear enhancement of the leptomeninges. That's compared to fungal infections or cancer that tend to cause this thicker nodular enhancement, although I was reading that carcinomatosis tends to cause a linear enhancement. And that's in contrast to enhancement in the pachymeninges, which affects the arachnoid and the dura mater. And there's no blood-brain barrier protecting those tissues. So anything that makes the blood vessels leaky can cause enhancement there. So things like granulomatous disease tend to do that, sarcoid, GPA, and tuberculosis. And our patient is in the leptomeningeal bucket. I will say a couple things that patients don't read textbooks, so I don't think this is always 100% true. And you can have inflammation of both the pachymeninges and leptomeninges. And things like nocardia can cause, a discrete lesion with some leptomeningeal enhancement. So there's all sorts of combinations, but this is maybe helpful in moving things up or down my differential. For cavitary lung lesions, I'm not going to go into this. Jen Spicer did a wonderful CPC in December where she talked about the differential for this, and this is her QR code for a study she really likes that goes over the differential for cavitary lung lesions. And then for multiple osseous lesions, again, we have multiple buckets. There are limited things that cause kind of multiple lesions, diffuse lesions. I think the first one that comes to mind for me is, of course, cancer. But infections like tuberculosis and dimorphic fungi can do it too. Inflammatory conditions like amyloid and sarcoid, as well as what I just put as other, which things like Gaucher's disease or sickle cell. And so putting it all together in this Venn diagram of overlapping diseases, the things that fit really nicely in the middle to me are cancer, tuberculosis, dimorphic fungal infections, and sarcoid. Some things kind of fit or maybe would fit better if this patient was immunocompromised, but that's really where I'm going to focus my effort in terms of diagnostics. I would be remiss if I didn't mention that there is kind of a brain, lung, or lung, brain, differential that's well described. There's a really great febrile podcast about this. If you're not familiar with febrile podcast, I suggest you give it a listen. And episode 2 was about this. This often really refers to discrete lesions in the lung and the brain, so like an abscess or a ring enhancing lesion, not as much the meningeal enhancement that was described in this patient, but I think it's always important to remember that there's a discrete differential for this, and you can see it is actually quite overlapping with what we've talked about. So for my differential for this gentleman, I think in the infectious side, tuberculosis and dimorphic fungi are at the top, still in consideration, but less likely would be Cryptococcus and nocardia. And from the non-infectious side, I'm thinking about things like cancer in this patient with a lung, mass, a lung cancer, a melanoma, truck drivers, they sometimes hang their arms out the side of the window, sarcoid, and then maybe less likely vasculitis. I want more information from the patient. I want to know exactly where he drives his truck. I want to talk to him more about any rashes and do a really thorough skin exam. I want to know more about how much he drinks, and then I want to reevaluate his sexual history. I found that sometimes you need to talk to patients multiple times for them to get comfortable enough with you to give a kind of thorough sexual history. And certainly syphilis can do weird things. I don't have an HIV test back yet. I'd like to understand that more. So for additional testing, I know the patient had an outpatient bronchoscopy. If it was at an Emory site and we were able to get the specimen, if we could add on the MTB PCR, that would be very helpful. If it was possible to specifically do a culture for nocardia, that would be great. From his blood, I want an HIV test. From the urine, a urine histoplasmosis antigen. A cryptococcal antigen is a really quick, really good test from the blood. I'd like to get a 1,3-beta-D-glucan. This isn't a very specific test, but it can raise my suspicion for a fungal infection. Of course, get an RPR again, because I'm ID and you know, I can blame syphilis for a lot of things. And depending what he tells me about where he's traveled, I might want specific testing for specific dimorphic fungi. And depending on what site you're at, this test might be different. So I didn't specify which one due to the factors that I can't answer now. Similar to Dr. Hutto, I really want a lumbar puncture. And additional to kind of the basic workup that we think about, I want a cryptococcal antigen. I'd be thinking about oligogonal bands and IgG levels. I want to get in a VDRL, and I want to make sure I saved extra specimens to potentially do some metagenomic sequencing or ribosomal subunit sequencing in the future. And of course, I want to talk to my colleagues and put all our heads together to think about what's going on with this patient, given a broad differential that goes outside the infectious diseases, including rheumatology, neurology, and our awesome brain radiologists. And that's it.
Awesome. Thanks, Dr. Witt. That was incredible. Thanks for sharing all that. And you really set us up for the next bit of information here. Shree, can we hear a little bit more about what happened on the submission?
Yeah, definitely. And so kind of like what Dr. Witt said, you know, with these MRI findings of this nodular leptomeningeal thickening, pretty much an interdisciplinary care approach was taken. And so from the get-go, infectious etiologies were now on the differential. And so they went ahead and started the patient on vancomycin, ceftriaxone, and acyclovir empirically. And then a lumbar puncture was subsequently performed to kind of do some of the additional workup. So results of this lumbar puncture showed a glucose of 28, an elevated protein greater than 200, and an opening pressure of 25. The first tube had a nucleated cell count of 74, which was primarily lymphocyte predominant at 70%. The fourth tube, again, nucleated cell count of 80, again, lymphocyte predominant. And then some of that infectious workup was started. So the CSF bacterial culture was taken. That showed no organisms. CSF, AFB, and fungal cultures also taken. Those were sent to the lab to process. And then the CSF meningitis and encephalitis panel was done. And this has quite a few things in it. And I went ahead and attached all of the different components of that panel to the slide. All of that came back negative as well. Okay, and then finally a CSF MTB, tuberculosis test, PCR was done, also negative. And with those CSF studies, a flow cytometry was done, and it showed numerous mononuclear cells, no abnormal hematolymphoid cell population, and no overt evidence of malignancy. Some additional workup from here that was performed was they did that HIV test. HIV test was negative, and they also did quantiferon gold, which also came back negative. Okay. And so during this time, while this infectious workup was being done, the bronchoscopy and biopsy results from previous resulted. And so they were able to get their hands on it. And so the right lower lobe transbronchial core biopsy ended up showing well-formed non-necrotizing granulomas. The cytology from the bronchoscopy lymph nodes also showed rare granulomas, and it was completely negative for malignant cells. And then the respiratory culture that was done also showed normal respiratory flora, no organisms, and no RBCs.
Thanks, Shree. Now, with this additional data, we'll have Dr. Witt step back in. Dr. Witt, we'd be interested in hearing how you incorporate this new data into your diagnostic thinking. Specifically, would you suggest any additional testing or any empiric therapy at this time?
Thanks so much. Yeah, so just to summarize, the new information we have now on this patient is that there's been no evidence of malignancy in any biopsy or on cytology of the fluid that was sent. There was non-necrotizing granulomas both on bronchial and lymph node biopsy, and these were negative for fungal or AFB stains. The patient is HIV negative and had a negative quantiferon gold, had a quite abnormal lumbar puncture, which we're going to go into a little bit more, with the negative MTB PCR from that lumbar puncture and a negative meningitis encephalitis panel. So this is a table I use when I teach the fellows about CSF studies. And I think I really want to focus in on the TB and fungal findings because the patient's time course of symptoms of 2 months is really not consistent with like a bacterial or fungal infection. And the combination of the headache, the cranial neuropathies, and the other findings fit more with these infections. And so looking at our patient, you can see that it's consistent with both of these infections. So, normal to high opening pressure, an elevated white blood cell count that's predominantly lymphocytic, elevated protein, a low glucose, and a negative, initial gram stain or smear, which in only really applies to tuberculosis and has a pretty low sensitivity. In terms of the negative culture to date, knowing that both of these cultures are held for an extended period of time, both of them have a relatively high false negative rate. These are difficult infections to grow from the CSF. And even the nucleic acid amplification or PCR tests have a relatively high false negative rate, which was true for our patient. And I wanted to point out that when we brought the multiplex panel to EUH in our microlab, we validated the different targets and did find that the cryptococcal target on the meningitis encephalitis panel had a false negative rate that was that we weren't that comfortable with. So that's why we tend to get a CRAG from our CSF. I also want to just point out, the other things on our differential that were not infectious and how does that align with our patient. So for sarcoidosis, the opium pressure can be variable. The white counts are often elevated in lymphocytic predominance. What I could find was that the protein tended to be elevated, which would be consistent with our patient, and a low to just barely normal glucose. And often we might check oligoclonal bands or IgG, and those may be elevated, although that wasn't given in our patient. Vasculitis and cancer were also on our differential. My understanding is that more than half of the patients with, brain metastases from a primary cancer will have similar abnormalities on their CSF. And vasculitis is potentially more variable. With patients with vasculitis, can have a perfectly normal CSF. So for the differential, with this new information of the non-caseating granulomas, negative cultures thus far, and no indication of malignancy, when I think about non-caseating granulomas, I think about infectious causes like atypical tuberculosis. Typically, it is caseating, fungal infections, specifically cocci, syphilis, and then non-infectious causes like sarcoid, metastases, and vasculitis. And these are all things that have already been sitting in our differential, right? So we're kind of marching down the same pathway. For me, the findings thus far maybe moved some things up my differential. So maybe I'm more suspicious for dimorphic fungi rather than tuberculosis, knowing that tuberculosis can be a very challenging thing to diagnose. But given the AFB stains were negative on pathology, even in a patient with, a large cavitary lesion, maybe that's fallen down. And same with cancer, there's been no evidence of malignancy thus far. I don't think that effectively rules it out, but it certainly maybe moves it down compared to sarcoidosis at this point. And I don't think I've gotten any information that effectively rules out any of my other, less likely causes. I think that where my differential, may have changed my testing. I think I still need to talk to Reem and probably the neurologist about sarcoidosis more seriously. And I'm maybe ready to pull the trigger depending on the other tests that I've already listed, if those are positive, on a 16S or 28S ribosomal subunit testing. just because I'm worried that we may not have an answer, and having these tests take a week or two to come back, and having that in our back pocket if we're still scratching our heads, a few days from now might be nice. I was asked to comment on empiric therapy and whether I would start empiric therapy in this patient. The things that I take into consideration about starting empiric therapy is it toxic? Is it going to impact further workup? Am I potentially going to get confirmatory test quickly, and so I'd only be holding therapy for a day or two more? Or do I have low confidence in my diagnosis that would kind of lead me to maybe hold therapy? Versus I would initiate therapy if the patient is critically ill or there's a high risk of delaying treatment any further. If I feel very confident in my diagnosis, despite not having kind of a gold standard diagnostic back, and if the confirmatory testing is delayed or maybe challenging to obtain. So for this patient, my number one infectious diagnosis on my differential is dimorphic fungi. And going through that list of things that make me figure out, whether or not I would start empiric therapy, I think how toxic are the drugs? That's complicated. There's different treatment for different dimorphic fungi, and certainly liposomal amphotericin is, toxic. The tests are going to be delayed. They're almost all send outs and could be a matter of days before they come back. I'm not that confident in my diagnosis. There are some tests that maybe could shift me up a little bit in my confidence that I don't have back yet. And what's the short-term risk of not treating before I confirm this diagnosis? If this patient truly has, fungal meningitis, it's actually moderately high. But I think with the information given right now, it's hard for me to say that I would start empiric therapy, but I could be persuaded depending on if some of that testing came back.
Awesome, Dr. Witt. Thanks for your expertise. Super helpful in helping us narrow down what we think might be going on here. So, Shree, what happened next?
Yeah, so at this point, given the fairly negative the negative infectious workup so far, as well as the MRI showing the leptomeningeal enhancement, as well as these non-caseating granulomas and the CSF parameters with elevated protein, the medical team went ahead and made a presumptive diagnosis of neurosarcoidosis. And so then next step, actually, I'll give it back to Dan there.
Yeah, so it was a great opportunity for Dr. Hutto to come back in. Dr. Hutto, for this discussion, we're hoping you would share your expertise on neurosarcoidosis with focus on diagnosis, treatment, and expected clinical course.
Okay, so I guess I changed my sort of schema to chronic meningitis with vasculitis and pulmonary cavitations, just to start with kind of highlighting the key things that I zeroed in on. So similar to Dr. Witt, but an illness course of 2 months, MRI showing leptomeningeal disease that is predominantly in the posterior fossa. Disease there can affect the major arteries that supply blood flow to the brain, including the basilar artery, the internal carotid arteries, the middle cerebral arteries, and the intracerebral arteries. So when you have inflammation or infection there, that can lead to vasculopathy or vasculitis because it's adjacent to that and it can affect those vessels. And that can lead to things like transient ischemic attacks, which may be what he was presenting with his left-sided weakness. The CSF showed a mild to moderate lymphocytic pleocytosis and low glucose. And then just noting that, there's non-exhaustive infectious and neoplastic studies are so far unrevealing, like what Dr. Witt said, but maybe there's some other things that we should add to the list. And then importantly, this is a person with systemic symptoms like cavitary mass, lymphadenopathy, and non-necrotizing granulomas. So all of these things here are actually pretty much perfectly consistent with neurosarcoidosis. So I can understand why this was thought of as kind of a key, at the top of the differential diagnosis. So the time course very much fits. Patients who have leptomeningitis related to sarcoidosis oftentimes present over the course of some months. The CSF profile is just as Dr. Witt pointed out, so low-grade lymphocytic pleocytosis with low glucose and elevated protein. Granulomas are supposed to be well-formed and non-caseating in sarcoidosis, and we've seen that in the biopsy. We talked about how meningitis is usually in that exact location for patients who have sarcoid, and patients with sarcoid can develop vasculitis secondary to this meningitis, and so that is also fitting in this picture. It's a well-described phenomenon that patients with neurosarcoidosis can have their course complicated by stroke and TIA, particularly when they have meningitis in those regions. The unusual pieces for sarcoid, I would say, is his demographics are perhaps a little bit less common than we would ordinarily expect. I'm less familiar with the pulmonary manifestations of sarcoidosis, but is a cavitary lesion something that we would anticipate, within 2 months or so of his disease onset. So some other things that I would consider in the differential diagnosis to sort of mirror what Dr. Witt said is particularly fungi. Has he traveled to any of these areas that where they are endemic? Certainly a couple of other things like tuberculosis is very hard to rule out in the CNS, so to speak, and it oftentimes causes a basal leptin meningitis with a similar CSF profile. There are some other disorders like lymphomatoid granulomatosis, which can cause meningitis. Usually parenchymal disease is more common, and they can cause pulmonary nodules as well that are usually basal predominant. The trick about this disorder is the granulomas are actually poorly formed, which is where the name comes from. So that seems a little bit odd. ANCA-associated vasculitis usually causes necrotizing granulomas, but meningitis is common, and so is vasculitis. And so there are some things that, that would make that sort of cross your mind as well. I think neoplasia is still sort of neutral in my differential diagnosis. It hasn't really moved up or down. The CSF, profile in the time course could be consistent. We usually don't feel comfortable excluding malignancy until we've tapped a person 3 times, and this person, it sounds like, has gotten 1 tap so far. Standard bacteria, the time course probably doesn't fit, neither does the CSF profile. The same for viruses. And then I would say, we've considered some primary neurologic vasculopathies here, but typically these are not associated with systemic findings, and so that makes those less likely. And surely migraines is off the list because we've identified an actual, abnormality on the MRI. So I would request a lot of the same things that I think Dr. Witt has alluded to, mainly oriented to around additional testing for fungi and cancer in the serum and the CSF. Again, I think vessel wall imaging is interesting to look for vasculitis, and I also want to talk to my colleagues. So the diagnosis of neurosarcoidosis basically rests on, is it a consistent clinical picture, and do we have pathology that confirms the diagnosis, or at least shows findings that are consistent with sarcoid? Like Dr. Witt alluded to, lots of things cause granulomas, including lots of things that cause non-caseating granulomas. And so it's not pathognomonic for sarcoidosis. So we try to combine it with, is this a consistent clinical picture? And I would say in this case, like we've talked about, the clinical manifestations do make sense with the basal leptin meningitis and possibility of vasculitis. The MRI findings are very much in keeping with neurosarcoidosis. The CSF profile is also very consistent. And then, we do have pathology from at least one organ that demonstrated non-caseating granulomas. And so in many respects, a lot of people would consider neurosarcoidosis to be really high on the list. You'll notice from this diagnostic, criteria that, as with any other neuroimmune disease, it mentions ruling out other causes, perhaps better explanations. In our diagnostic criteria, we don't actually have advice on how to do that or what to test for, or what things to consider based on what phenotype of neurosarcoidosis we have, including meningitis. And so there's less guidance on that. And then I'm a huge fan of Hickam, who actually did some time at Grady. And, so his sort of famous saying is, just because, a patient can have as many problems as they please, so to speak. And what I have learned is that just because sarcoidosis is present in one organ doesn't necessarily mean that it is the thing causing the problem, in the nervous system. And so we oftentimes make that leap. We do so readily, but there's no necessarily a guarantee there. But with that said, it's really hard to biopsy the CNS because you run a serious risk for mortality and morbidity. And so, taking that risk is substantial. And so a lot of times, if we find it in the body, that is sort of the end of the workup. I was asked to weigh in on treatment considerations. This phenotype of sarcoid would be considered amongst the most severe. So somebody with leptin meningitis with possible vasculitis causing, TIAs would put him at risk for ischemia in the brain and also the direct damage from the inflammation. And there were recent consensus position paper from experts in the field discussing how to treat various phenotypes, and the field is moving towards an induction approach, actually. So some people would even consider not only giving steroids, but methotrexate and infliximab as sort of as an upfront, treatment in these cases. And, And surely steroids would be, the first thing that we would do, and then we would consider the other possibilities based on, how the patient does over time and what additional diagnostics come back and how much that firms or refutes, the diagnosis. When patients are given steroids for neurosarcoidosis, typically we see a response within days to weeks, and so that would sort of be the expectation. Some phenotypes are more refractory than others, though, and so maybe steroids are not enough in some, and this is a scenario where maybe steroids could be inadequate. And so we have to think that, if a person gets steroids and maybe they don't do the very best in the world, maybe it's because it's a refractory phenotype. But what I will say, if they don't respond to steroids, sometimes that's an important moment to take a step back, revisit the diagnosis, especially in patients who did not undergo a biopsy of the nervous system to confirm that what's in the nervous system is actually sarcoidosis. And with that, I'll turn it back over to you all.
Thanks for sharing your expertise there, Dr. Autl. Shree, let's hear how the remainder of the submission turned out.
Yeah. So again, with this presumptive diagnosis of neurosarcoidosis, some further workup was done to kind of guide treatment options. They got a serum IL-6, serum SIL2R, HPV, which came back negative. They got an MRI optic nerve just to look up optic nerve involvement. And that actually showed some improvement in the leptomeningeal disease. Okay, and so then going on to treatment. So treatment for this patient, they decided because of this atypical presentation, with the initial presentation being consistent with TIA, to kind of treat for both stroke and inflammation. And so for the neurosarcoidosis and inflammatory aspect of this, they started him on IV methylprednisone, 1,000 milligrams daily for 5 days, transitioning to a prednisone 60 daily taper, and then going down by 5 milligrams each day thereafter. Each week thereafter. Then they also started him on methotrexate, a steroid-sparing treatment, and then followed with rheumatology outpatient. And then for stroke, they gave him aspirin 81 and atorvastatin 80 daily. And so the methylprednisone was started while he was in the hospital, and the patient actually had some pretty good improvement in his symptoms. So his headache and his strength improved. They did note that he had some intermittent hallucinations and confusion at night, but because he showed that improvement, they went ahead and discharged him on a prednisone taper, aspirin 81, atorvastatin 80, and vitamin B12. Okay, and so you might think that this is the end of our story, but in reality, the patient re-presented to the ED the very next day. And so this time around, he came with a very severe headache. By the time he was evaluated, though, vitals were stable, he was slightly in pain, no focal neurologic deficits. Labs were notable for sodium of 128, a T-billy of 2.8, and a mild leukocytosis. ED physician was able to see the records, saw this diagnosis of neurosarcoid, offered IV dexamethasone treatment, which the patient received, and then also offered hospital admission. But the patient, given that he had a neurology appointment scheduled, outpatient, elected to be discharged and follow up outpatient. So then he left the hospital, and then 2 days later, he again re-presented to the ED. This time around, he had a bit of a clinical deterioration. And so he had worsening headache. He had some mental status deterioration that was documented. So he was nonverbal. He was talking to himself in an incomprehensible manner. And then it was documented that his symptoms worsened 5 p.m. the night before, right after taking his prescribed prednisone. And something else they said was he was unable to use the bathroom independently on his own. So presentation during this hospitalization. So vitals were notable for a temperature of 100. The rest was pretty stable. Physical exam was documented as obtunded. Patient was stiff, unable to sit on a wheelchair, eyes intermittently deviating to the right arm drawn into the abdomen, right leg pulled up, and then left arm and left leg moving spontaneously in seizure-like activity. He had a leukocytosis WBC of 16, as well as a differential that showed a left shift, 91% neutrophils. And so a CT head was again done, and this one showed interval enlargement of the anterior horn of the lateral ventricles. And so this finding was concerning for developing hydrocephalus. And because of this, the patient was, due to the seizure-like activity, he was eventually started on Keppra and benzodiazepines, and then had to be intubated for airway protection. Because of this developing hydrocephalus, neurosurgery was consulted, and neurosurgery ended up placing an EVD in the patient. And then it was determined that the patient would need continuous EEG monitoring. And so he was subsequently transferred to a tertiary care hospital for that monitoring. The results of that CEEG showed predominantly theta frequency background slowing that was read as being indicative of moderate diffuse or multifocal cerebral dysfunction. And then the CTA head showed some luminal irregularity and severe stenosis of the bilateral M1 segments, mild luminal irregularity of the LM2 segments, and likely bilateral posterior cerebral arteries. Okay. After being transferred to the new hospital, to the tertiary care center, his vitals were also noted for a new temperature to 101 degrees Fahrenheit, as well as a white count of 16.4. And so then a repeat LP was performed. And so that LP showed a glucose of 85, a protein of 11, and a white count of 1. And of note, that previous LP showed a glucose of 28, a protein of greater than 200, and a white count of 74. And so then a repeat CSF biofire was sent, and the patient was again restarted on empiric bank ceftriaxone, azithromycin, and acyclovir.
Thanks, Shree. Now with this new clinical presentation, I was hoping our discussants can each share how this affects their thoughts on the working diagnosis and management. So we'll start with Dr. Hutto, followed by Dr. Witt. Dr. Hutto, what are you thinking at this point?
So I think, this is a very challenging clinical picture. I did write another aliquote, so I'm not sure if y'all want to see that, but, I think it's extremely challenging clinical scenario. It seems like he's had at least a mixed response. He improved in the hospital. And many of the objective things that we look at to determine if they're responding to treatment, especially for neurosarcoid, did actually get better. So his degree of leptomeningeal enhancement improved. And his CSF actually radically normalized with steroids, and so that's an interesting point of note, I think, from the neurosarcoid perspective, and when we consider infection as an alternative. But he worsened, began to worsen markedly within the first couple of days after he was discharged, and so despite having actually received high dose IV steroids and being discharged on high dose oral prednisone, he did begin to worsen, and his imaging began to change. So he did develop actually, vasculopathy. His blood vessels were normal when he originally presented. And now they began to show some changes that raise concern that there are stenoses developing that could be a sign of vasculopathy or vasculitis. And then he's developed frank hydrocephalus. The patients with neurosarcoidosis with leptomeningitis can develop hydrocephalus. That's another phenotype, but it is concerning in this time point. And then I would just say that the hallucinations and confusion could probably easily be prescribed to steroids. Could also, of course, be due to something that we're missing as the underlying diagnosis. But, so it's a challenging situation to be in, I think, from the provider's perspective. So I'd say neurosarcoid is still plausible. This is a highly refractory form of the disease. We talked about certain aspects improved as we would expect, but his clinical situation did not. And as a neurologist, I will just say anecdotally, the one thing that is always in the back of the mind in terms of if things are not going the way that we're thinking is to consider fungi in particular, because sometimes I have seen fungi respond to steroids initially within the first few days to weeks with just steroid treatments. And that may have something to do with the brain is very responsive to steroids whenever there's vasogenic edema. And so if the fungi have caused that, then perhaps that's why they're responding. If the fungi have caused vasculitis, sometimes that will help. Steroids will be helpful for that. And so we have to keep that in mind. And of course, lymphoma could do the same. And so I would just, reiterate, I think we need fungal diagnostics from the CSF. Maybe if our targeted testing is unrevealing, consider metagenomics, repeat cytology and flow, and then see what ID and Room think. And then I think, it should be a multidisciplinary discussion at this point, but we could consider additional steroids, but also need to take the issue of fungal coverage very seriously here. And with that, I'll turn it back over.
Thanks, Dr. Hutto. Now, Dr. Witt, what are your thoughts?
Yeah, and I think you guys are going to laugh that Dr. Hutto and I did not collaborate on our slides, but I too was invoking Dr. Hickam for these developments that, I would be asking Dr. Hutto, is this anticipated with neurosarcoidosis? And if the answer was no, certainly going back to Hickam's dictum, And I think this is especially relevant for immunocompromised patients, right? And at this point, this patient is now immunocompromised. I don't know exactly how much treatment they've gotten, but they've gotten at least some course of high dose steroids and methotrexate. So he's really going to fit nicely into this. I think the other thing I always encourage teams to do when a patient presents like this, where they have this very interesting disease, they're very sick, everyone's confused, is to make sure you go back to basics and do a thorough physical exam. I've seen patients, where the patient is very sick from something else and then has a fever, and you go in and you very quickly find an thrombophlebitis on their arm, and they, 2 days later, pop positive with staph bacteremia. So I think it's important in this patient who's been hospitalized to make sure that you're not missing common diagnoses and that you're kind of not putting on your blinders, just looking at what happened in the brain and evaluating the whole patient. As I mentioned, I would be discussing with my colleagues about the expected course and these new blood vessel changes that Dr. Hutto described, and what they could imply. And then, we had a whole host of infectious testing that we wanted to send, or now may be more mature, including the fungal cultures. And if we haven't sent any of that, I think it's time to send it, from the CSF and the blood, and see if we can gather any more data from that. And yeah, that's it.
Thanks, Dr. Witt. A huge thanks to you both on once again sharing your expertise in this case. Now, Shree, I hand it over to you to give us the remaining information for this case.
Yeah, and I'll try and be conscientious of time here a little bit. But so this was actually the point in time where I first saw the patient as a part of the infectious disease team. And so we were consulted for this new fever and to consider a more broad differential, kind of what our discussants were talking about right now. And I'll walk us through some of our expanded workup here a little bit. Again, the bacterial CSF cultures that was done through the BioFire all came back negative. The viral CSF also all came back negative. We got some more serum studies. So this was kind of what was new that we did. We got an RPR, Bartonella, IgG, IgM, Coxiella to evaluate for Q fever, West Nile antibody, Brucella antibody, serum cryptococcal antigen, all still negative. Got another urine study, urine histoplasma, again negative. And actually, the very day that the infectious disease team was going to sign off of the patient, our last test came back, and this was a CSF Coccidioides IgG IgM, and that came back positive. And so apparently it's possible for this to be a false positive. And so we ended up getting confirmatory testing, a CSF antigen and complement immunofixation, which also came back positive. And so this constellation of symptoms felt like this new diagnosis, we felt really explained the constellation of symptoms. And so then our final diagnosis was neurococcidiomycosis infection. And subsequent treatment was pursued. We started on high-dose fluconazole, which quickly transitioned to amphotericin B, along with a steroid taper. The patient ended up having a pretty prolonged hospitalization and ultimately finished a 6-week course of IV amphotericin B, followed by fluconazole 800 indefinitely. Unfortunately, the patient was very critically ill and did not make any significant recovery despite prolonged therapy, and was eventually transitioned to an LTAC facility. And this was an imaging MRI of kind of some of that edema that developed early on around the time of the diagnosis was made. And that is everything I have. I want to send out my thank yous. Thank you so much to Dr. Wendy Armstrong, Nora Lockery, Jochebed Ernius, and Brandon Warmer, as well as all other members involved in the care of the patient. And then obviously thank you to Dr. Dan Barbato, Dr. Witt, Dr. Hutto, and Dr. Fatke for helping present and create this presentation. Thank you. Any questions?
Well, I will also just add with Dr. Witt, I included a slide with a picture of John Hickman on it from the Indiana University website and highlighted the part where he worked at Grady. And I almost included it, but I wasn't sure about the copyright issue. And so I just left it out. But your painting was actually far superior.
Yeah, it's nice. It's nice to know we're on the same wavelength, Spencer.
It looks like no questions from the audience. Thank you again to everyone for this incredible case presentation. Thanks to Dan for organizing this. Thanks everyone for being here. Please do go ahead and scan that QR code to submit your evaluation and get to see me. And then we look forward to seeing you next week for our Division of Hospital Medicine CPC. Thanks, y'all.
Thanks, everyone.